Thank you. Let me see. This is forward, right?
Green button is forward.
The green button is
the
forward?
large green one, the upper one.
The large green, thank you. First, I'd like to thank the organizers for inviting me, and the title assigned to me was Fibrosis and Upstream Therapy. It's staying upstream. It's not going downstream.
This one, yes.
These are my disclosures. And just to, I will want to show a few slides from the guidelines indicating how bad AF is. And we all know that AF is very bad. But we also know that many of the things that are listed here, like death and stroke and cognitive decline, are not necessarily affected by the treatment of AF or have not been proven to be affected. The only strong proof is that it affects quality of life if you treat AF. Hospitalizations are not effective either. What we have seen, and that in the recent guidelines, that lifestyle changes in upstream therapy have moved up in the priority of treating AF. And I would like to say that if we were successful in this, that we would not have been here today, because we're not. This is a combination of important studies that have been presented, and basically they show that, this is the pointer, ARBs
Yes.
do not prevent AF. ARBs prevent AF in hypertension and LVH. ACE inhibitors and ARBs prevent AF in hypertension. So we can do something, we can affect something, but taken together, we're not so successful in performing upstream therapy and preventing AF. So this has been elaborated by the previous speaker, and I will not go into it, but there is a relation between the amount of fibrosis in the left atrium and the success of rhythm control treatment, be it catheter ablation or surgical ablation or medical therapy. And we showed 2 years ago that not just the amount of fibrosis is a prognostic factor, but also the type of fibrosis. And we showed that there's a difference between patients who demonstrate thick strands of fibrosis in the heart versus those in whom it's more diffuse. And sorry for pointing at your head, Jos. And it may well be that this is the clinical correlate. These were excised left atrial appendages from patients undergoing thoracoscopic surgery for AF. So this is actually patient material of patients with AF. And it may well be that these thick strands represent the endomysial fibrosis that Sander just showed, but basically we just don't know that. But we do know that there's an association between those and the lines that anchor reentrant activation. This is an example of optical mapping of this human tissue, and during baseline stimulation there's just planar activation, but if you stimulate with the short coupled extra, you see that at the location of those lines of fibrosis, lines of block occur around which activation can propagate and can initiate reentry. And also, there was a relation between the presence of these thick strands of fibrosis and the conduction velocity. And the most important relation was that longitudinal conduction velocity, so conduction velocity along the fiber direction, increased in patients in whom the bundles are more separated, which of course makes sense. This is all done in excised atrial tissue from patients, and as interesting as I find this, it's not very useful as a clinical prognosticator. So we are looking for mechanisms and for biomarkers that can help us assess the fibrosis in the heart and help us to select patients who are suitable for ablation therapy and who are not. And one of those biomarkers is galectin-3. And galectin-3 is a compound that binds to the TGF-beta receptor. Sorry, let me go back. That binds to the TGF-beta receptor and in fibroblasts induces fibrosis via SMAT pathway and via transcription of procollagen, alpha-smooth muscle actin, causing differentiation of fibroblasts into myofibroblasts and to the production of extracellular matrix. And also, there's an effect of galectin-3 on the atrial myocyte, which in short words results in reduction of the, this is when you block it, in an increase of the dominant frequency during atrial fibrillation and a shortening of the action potential duration, which is of course also arrhythmogenic. And the authors did very nice experiments in patients undergoing catheter ablation where they collected blood from the left atrium and from the coronary sinus and measured the amount of galectin in it. And they showed that there's a difference between persistent and paroxysmal AF, with persistent AF patients having a higher concentration of galectin than paroxysmal AF, and that there's a correlation between the cycle length of the atrial fibrillation measured in the electrocardiogram, and that this correlation holds true both for the coronary sinus derived blood and from the left atrial derived blood. They further did experiments in comparing these numbers with the left atrial volume, and again there's a nice correlation, and the breakoff value is 13.6 for the blood collected from the CS and 11.9, and if you're below that, then you have a nice and small atrium, and if you're above that, you have a big atrium. So it suggests that clinically there's some correlation without saying anything about the mechanism. So the investigators went into isolated sheep fibroblasts and showed, and this is kind of a complex figure, and I will not go through all of it, but they show that if you increase galectin, you increase the relative cell number, so the proliferation of the fibroblast, and that you can block it with GMCT. You go back to normal, and this is a positive control. And similarly, the effect of TGF-beta, which is the driver of atrial fibrosis, is blocked by GMCT. They also show that the remodeling changes in the sheep, and this is a rapidly paced sheep heart, are partially reversed or do not progress as much if you block the galectin pathway than if you don't do that. This is the sham-operated animal, and this also accounts from the endocardial area. So, and there is a relation between the biomarkers of fibrosis, the and terminal procollagen 3, and the blockage of the galectin pathway. So this sounds all very nice and very promising. So we decided to test this in our series of patients undergoing epicardial hybrid thoracoscopic surgery for AF. And we collected in those patients blood before the procedure and after 6 months. And also we determined the amount of protein in the excised left atrial appendage in order to be able to correlate the circulating galectin with the actual left atrial galectin. And we correlated these data with the freedom of atrial fibrillation after the thoracoscopic procedure. These are the patient characteristics: 98 patients, 75% male, approximately half of them persistent, 17% had a previous catheter ablation, and the left atrium volume is enlarged or severely enlarged. And to our surprise, there was no difference whatsoever in the circulating galectin between patients with no AF recurrence and patients with AF recurrence. And there was no relation when we made a cutoff between high and low galectin at baseline. There was no relation between the circulating galectin and the galectin in the left atrium. And there was no relation between the histology, and this is just a typical example, and as you can appreciate, this is bad fibrosis and this is good fibrosis, and as you can see here, both the serum galectin and the left atrial galectin are a lot lower than in the good fibrosis. So this got us puzzled. But now if we compare the galectin measurement after the procedure, by hypothesizing that atrial fibrillation itself also induces these markers of fibrosis, and that by taking away atrial fibrillation, you may take away one of the pro-fibrotic triggers. And now if we look at the 6-month data, we see that there's a strong correlation between outcome between those patients who did not, with a low galectin at 6 months, they did a lot better than those patients with a high galectin at 6 months. And the AF freedom here is the number of patients. All the patients didn't have any AF recurrence at the moment of blood drawing. So they had a similar amount of AF free time. The AF recurrence occurred after the drawing of the blood. And we did a sub-analysis, including also the patients who recurred before the blood drawing, and the results are similar. So there's a relation between the amount of galectin after the procedure, and there's also a relation between those patients in whom the galectin in the serum increased, who do badly, and in those in which or in whom galectin-3 decreased or remained unchanged, indicating that aside from atrial fibrillation itself, there are remote processes causing pro-fibrotic signaling and affecting the arrhythmia in the left atrium. We did a multivariable analysis to see in which patients there was an increase in galectin, and these were females, patients with persistent AF, and patients in whom we found thick fibrotic strands in the histology of the left atrial appendage. So those are patients that, irrespective of restoring the rhythm, have a bad prognosis for ablation of atrial fibrillation. And this is just to summarize that. It's not a very useful prognostic marker if you use the baseline data. There's no correlation between serum and tissue galectin-3, and the change in galectin-3, however, upon AF elimination predicts atrial fibrillation recurrence. And those patients in whom galectin-3 increase include female patients, patients with persistent AF, and patients with thick strands of left atrial fibrosis. So is there no hope at all for upstream therapy? Because that's what we started with. And I will show you 2 slides of a recent paper by Jolien Neefs, where she looked at all the data published on mineralocorticoid receptor antagonists blocking the aldosterone pathway. And that is amazing, because if you do that in all the studies that have been published, and most of the studies are heart failure studies, but there are also studies in patients without heart failure, there's a reduction of 50% in the occurrence of atrial fibrillation. And that holds true for the randomized trials, but also for the observational trials. It holds true for new onset AF, for patients who did not have AF in the first place, and for recurrence of atrial fibrillation in patients who have been diagnosed before. It holds true for heart failure, and for post-operative AF, there is no significant relation, but the signal also goes in the direction that it's favorable to block the aldosterone pathway. So, to conclude, I think that left atrial thick fibrotic strands, as measured in patients with atrial fibrillation, form a substrate for AF, and that goes beyond the percentage of left atrial fibrosis. Galectin-3 is not a biomarker for either left atrial fibrosis or for the outcome of epicardial hybrid thoracoscopic surgery for AF. And the change in galectin-3, as I showed, upon elimination of atrial fibrillation is an important predictor for AF recurrence. Targeting atrial fibrosis, for example, by blocking the aldosterone pathways, seem promising as a potential upstream therapy and need to be tested in primary and secondary prevention of AF. Thank you for your attention.
Thank you very much for this excellent presentation. Questions? Yeah.
What about reversibility of the fibrosis? If you compare replacement fibrosis and interstitial fibrosis, could you make such a distinction between this type of fibrosis that you showed? And did you see any difference between the groups with the raised levels, if there was a difference in the extent of ablation lesion given?
Yeah. The reversibility, if you accept histology as a gold standard, then we cannot say that because we only have one chance of getting tissue. So we are looking for ways to assess fibrosis non-invasively by either biomarkers or with imaging. We have not been very successful with imaging so far, but we are working on it. And in terms of biomarkers, we're still puzzled. We just don't really understand what we're looking at. And the point is, of course, that what you see in the blood is a composite of everything that happens in the body, and the left atrium is only a very small structure. As to your second question, as whether the amount of ablation differed in the outcome, there was no correlation.
Professor Giraudot?
The LA is essentially an elastic conduit. Did you measure the impact on the fibrosis, especially on the recall of the LA at an early diastolic LV? What that recall because of suction of the ventricle. Yeah. And this is the flushing of the left atrium. This is a very important little piece of physiology.
Yeah. We are in the course of assessing that by looking at left atrial strain on echocardiography. And the main results so far are that with ablation, the strain, so the shortening of the left atrial decreases, both in patients in whom only a PVI is employed, as in those patients in whom a more extensive lesion set is employed, where you can nicely see that the location where the lines are correspond with the segments of the left atrium that do not shorten any longer. The meaning of that is very hard, also as a biomarker, because the strain goes down, irrespective of success or failure. It just goes down more in patients with recurrences. But to use your baseline echocardiogram to predict which patient will be successful for ablation is something that we have not succeeded in yet.